First thing, how do you answer questions on hematology? Number one, you have to prioritize based on the condition that they give you. Remember, the prioritization doesn't mean that when you see your question, you're going to look for what I'm rating out, sickle cell, leukemia. No, I mean based on the diagnosis of the patient, there is certain things you should prioritize. For sickle cell patient, you should prioritize what? Hydration and oxygenation. For leukemia, somebody is to neutropenic, make sure you're preventing infection. That's prioritization to take care of that patient. If patient has hemophilia or thrombocytopenia, what is the problem with those conditions? Bleeding. So prioritize bleeding. Two, as you, based on the question, whatever they give you, as you prioritize, then watch for keywords in the question. If you hear about sudden pain, most of the time they're talking about sickle cell disease or crisis. So that's the key for you. Severe bleeding may be something hematological like hemophilia, DIC. So those things you can be coming to your mind. And if they start talking about fatigue, Paula, think about the patient is anemic. Sometimes they will not mention it, but it's there for you to pay attention to. Then you got to provide your intervention. It's the same thing as number one, prioritize your intervention. Intervention heresy. Basically, you're trying to hierarchy. Basically, you're trying to prioritize what you should do first. Of course, stabilize with fluid is good. Most of the time, if you have a sickle cell patient, fluid, oxygenation, transfusion as needed. If the patient need to be treated with antibiotic, hey, treat it, especially if they have DIC. Due to sepsis, you need to give it to them. If they need medication to be able to stabilize them in the beginning, then give it to them. Of course, you got to pay attention to life-threatening complications like tumor lysis syndrome. We'll go through them and you know what it means because of the electrolyte abnormality associated with that, like hyperkalemia, that can affect your heart and you go into arrhythmia. In DIC, there will be excessive bleeding everywhere. So you got to prioritize. This is what is going to kill them. And about the pharmacology, know the side effect. Know the side effect of each medication. One main side effect, one priority, like Ibuprofen alpha, it's not anything except hypertension before they get to stroke. They're going to clot. But before they do that, as you increase your hematocrit level, you're going to clot. But before you get there, number one thing you would do is hypertension. And that is the first thing you got to intervene. You got to monitor for some labs like anticoagulation. So those are the key, quick 5 things you need to know as you answer questions in terms of hematology. Now, some key labs, they will give it to you in a case study. If it's not a case study, you just have to know that these are the normal value. You don't need to memorize it, but just picture it and say you can look at it. You know, some of them, when they give you platelets, you want something about 150,000, right? All these things, the VBC, you want it to be between 5 and 10,000, right? All these things, you just have to picture it in your head and then when they give it to you, you say, oh, I know this is normal as you read the case without not going through the values they've given you. But when it comes to clotting factors, you have to know that. Clotting disorders, this number, you got to memorize it. PTT, as you know, this is associated with what? Heparin, right? When somebody is on heparin, you check in their PTT. Right now, you listen to me, your PTT is 30 to 40 seconds, right? That's how long your blood clot. If I give you heparin, it will take a longer time. Therefore, you multiply the lower one, this 30 by 1.5, and the upper one by 2.5. So you can see this is your normal range when you taking a PTT or you're on heparin. So if you, and these apply to heparin drip. So the highest normal that you can get at 2.5 times 40, basically it's like 100. You don't want to go past that. Most people will say, hey, 75 is good. But when you're going very, very high, usually 75 is a good number. So those are the things you have to know. The lowest one you can be at least 60 to 75. That's why people say 60 to 75 is good number. Anything above 100, you know, you've gone too far. INR, the same thing. Somebody is taking Coumadin and PT, their PT Normal PT is 11 to 11.5. You do the same thing. You multiply the lower one by 1.5 and the upper one by 2.5, right? So the highest normal they can go for the, in terms of your PT, if you multiply 12.5 times 2.5, you're getting 31, right? So those are the things, 31 seconds basically average. And your INR is usually 1. So if you're on Coumadin and go to 2.3, these are numbers you just quickly have to know. There's different kind of anemia. Easy way to remember them. Okay, quick facts, right, about anemia. Iron deficiency anemia, most common cause is blood loss or poor nutrition, like alcoholic who doesn't eat. Nutrition is bad. You don't take iron. Pregnancy patient who doesn't take iron or bleeding. But more normal one is bleeding loss. If they give you a patient, an older patient who has iron deficiency anemia, number one thing you should think about is a colon cancer. That's number one. Any patient who's older with iron deficiency anemia, number one cause is blood loss. What are the symptoms? That's what they will give you. Power, fatigue, weakness, spoon-shaped nails. Those are all buzzwords you will see in the question. The lab work or their lab will go down. Treatment, iron supplement. And don't forget, iron supplement, what they're going to ask you, constipation. So you got to teach them about what? Constipation, hydration, exercise, and what? High fiber. Those are the things. And then the key buzzword for iron is take it with vitamin C, right? Don't take it with antacid. This is very, very important. Okay, so these are little things you need to know. That's the NCLEX fact I'm giving you. What is pernicious anemia? It's just because they have vitamin B12 deficiency. That's all. And it's due to intrinsic factor, which is responsible for absorbing this. Most of the time is autoimmune. They have the same symptoms like anemia patient, but they have specific neurological symptoms. So iron deficiency anemia does not have neurological symptoms. These people have neurological symptoms. Treatment, give them vitamin B12 injection. It's a lifelong, that's the teaching. They don't stop it because they lack intrinsic factor. It's going to take a long time. The rest of their life, they will need a shot. Aplastic anemia, the word aplastic means everything is affected, right? So most of the time it's coming from the bone marrow. They are anemic, but they're not just anemic because the bone marrow is destroyed, their white, the VBC is low, and their platelet is low. So anything that affect your bone marrow, sometimes viral infection can cause that. And they have loss of platelet, loss of white, the VBC, and loss of RBC. So they both what we call pancytopenia. This, and they are fatigued because of what the RBC, they are bleeding because of the platelet and infection. All these patients will need replacement of all this subunits. Most of the time, it may be cancer patient who has pancytopenia is getting chemotherapy. So you have to know how to replace their red cells. You have to know how to replace their white cells, and you have to know how to replace their platelets. So these are key things I'm trying to let you focus on so that you don't have to memorize. There's some disorders you also have to know. Hemophilia. Do you have to memorize it? No. There is clotting factors that are responsible for you to clot. And that is why we take heparin and warfarin to prevent it from clotting, right? There are these people who basically they lack these factors that the heparin or coumadin blocks, right? They lack those factors, and therefore they can bleed just like that. They can bleed if they have small cut. So hemophilia A, they have factor 8 deficiency. Hemophilia B, factor 9 deficiency. What is your board going to ask you? You see some young kid with excessive bleeding, and number one, hemochromatosis, joint bleeding is the key. They are not sickle cell patient does not bleed into their joint. These people bleed into your joint. This is the key aspect to distinguish it between this hemophilia and sickle cell. So excessive bleeding, but mostly is a joint bleeding. what is your B-sharp moment, your prioritization? When they give you a case study, they give you a standalone question on a patient with hemophilia. Don't worry about injection. Don't worry about bleeding precaution. Number one thing you should do, and if they come in and they bleeding, is replace what they need. If they need factor 8, give it to them. If they need factor 9, give it to them before you talk about bleeding precaution. They lack the factor to clot. So while you paying attention to bleeding precaution, they still bleeding. So give them the factor that they need. What is DIC? It's disseminated intravascular coagulation. That means what? We are consuming your coagulation factors, and because of that, you're going to bleed a lot. And so they're going to bleed a lot. They also will clot. So there's two things that happen, right? So you have to pay attention to that. They're going to clot, they're going to bleed. We're consuming all their coagulation factors. Most of the time, this may be sepsis, you can have pancreatitis, you can have trauma. It can be multiple factors that will cause the individual to even pregnancy during birth. They can develop DIC. So the key pathology is what? Look for the buzzword. Bleeding from all IV lines is the key. So they'll be bleeding. And since we're consuming all your coagulation factors, we'll be consuming your platelet. They may have bruising. Okay. It may cause really sick individual. Treatment is to replace all their therapy that they're needing. And then they may need something to prevent them from clotting too. So these are little things, but I just want you to pay attention to the key, the word. This is very brief information in case you're struggling, just to understand what is going on. So when he asks you a question, the priority is bleeding, bleeding, bleeding. So resume, provide transfusion products to help with the stopping the bleeding. There's another disease process. It's a disorder called thalassemia. Do you have to memorize it? No, it's like sickle cell. They have genetic disorder causing hemoglobin production that can affect it. The hemoglobin is different. It doesn't form a sickle cell shape, but it lacks certain genetic aspect of it. It's deformed. And because of that, they present certain way. They may have weakness due to anemia, fatigue, pallor, but they may have growth delay, especially in children, and deformity due to marrow expansion to produce more red blood cells. So that is the key, right? So the treatment is what? Regular transfusion, and they may break their red cells, and they may have iron overload. And therefore, because of that, these people will need a chelating agent. That means antidote for over excessive iron. That's all. You don't need to memorize it. The other one that most people know is a sickle cell, right? The same thing. Hemoglobin assume a sickle shape, and the form is the sickle shape, preventing from flowing easily in the blood vessels. Therefore, in the process, it forms a clamp, and that causes ischemia, and they have crisis. What happens is when you're dehydrated, when you're stressed, or you have infection, or there's less oxygen, that is when you form more sickle. Therefore, in order to prevent it, take care of all those information. And you also want to prevent these people from uh, um, they should avoid triggers and have vaccination to prevent future problem like infection. The symptoms they will present with is due to ischemia because blood is not going to the area that the sickle red cells has blocked blood flow. So you can have ischemia, they have organ damage that causes the pain, right? And they may have jaundice because of the red cells breaking down and bilirubin showing up on their skin as jaundice. Treatment, break the blockage, right? Hydration first, then oxygen, then you manage their pain. Most of these people, stronger pain medication. You cannot give them acetaminophen. They need opiate. And treatment is what? Prevention. The key to remember treatment is HOP, right? HOP, hydration, oxygen, pain control. Hydration, oxygen, pain control is for sickle cell disease. So HOP, that's the order you go. Okay? Thrombocytopenia. All it means is low platelet, right? This can be caused by medication. Your bone marrow is not working, like the plastic anemia, or it may be due to you immunocompromised or autoimmune. Platelet, signs of platelet is not anemia, fatigue, right? Platelet, usually you're going to bruise, right? Bruising and petechia, right? Those are the key signs. Bruising, petechia, and bleeding gum are signs and symptoms of low platelet. Intervention, what do you want to do? Anything that block platelet, they should avoid it. Aspirin, they should avoid trauma because then they're going to bruise easily, and you may need transfusion of their platelet. This is key. Heparin-induced thrombocytopenia. It's not the same as regular thrombocytopenia. The word is heparin-induced. So you don't even have to memorize. I give you heparin and you develop thrombocytopenia. Therefore, what? Anybody who takes, you give them heparin, watch for their platelets. That's the key aspect. The concept you're supposed to know. It's an autoimmune response to giving the patient what? Heparin, right? The problem is you're giving them heparin for them to prevent from clotting. In the process, when they develop antibodies to the heparin, they rather form clot. So that's what we call autoimmune thrombocytopenia. That clot consume all the platelets. So they form thrombosis. The bigger problem with heparin-induced thrombocytopenia is thrombosis, no bleeding, right? What is your board want you to pay attention to? When you give somebody heparin, the platelet is going to go down. By the fifth day, fourth and fifth day, if it drop more than 50%, then you call it heparin-induced thrombocytopenia. There's a risk of clot, no bleeding, more clot than bleeding. So we check for DVT, stroke, and you stop heparin. They should never get any more heparin. You have to give them any other non-heparin anticoagulation. So they can get warfarin, they cannot get enoxaparin. It's also a form of heparin. It's a lower molecular heparin. What are the symptoms that will be showing? Petechia, clot formation, shortness of breath is all clot. So your intervention, stop on heparin, use a direct thrombin inhibitor like agatrobans, right? I call them agatrobans. They are Zabans as their last name. If they give you any anticoagulation that is not heparin, you'll pick it, right? Avoid platelet transfusion because it can worsen the thrombosis. It's being consumed. It's not because they like platelet, it's because of the heparin. So if you take the heparin away, they'll be fine. Never reintroduce heparin or lower molecular heparin. That's what I mean by that. Hemochromatosis is another condition they may ask in the case form. This is due to excessive iron. So if you have too much iron in your system, it will deposit in tissue like your liver and other places. And therefore, you're going to have some fatigue, joint, bronze skin, and diabetes because it deposits on your pancreas. Most common organs that is destroyed is your liver and your heart. What is the problem? They have too much iron. We got to do phlebotomy. So they go, it's like vampire them. You want to vampire them. You take them, and every week they may have 3 or 4 times blood draw to reduce the iron level. Okay, so you want to prevent iron supplement or vitamin C to prevent excessive absorption, right? Sometimes you see this word, myelodysplastic syndrome, is related to malignancy hematology. It means the bone marrow is going crazy, right? A group of disorder that will cause destruction of the bone marrow. One red cells will go AWOD and they become more red cells, and therefore your platelet and white cell is in trouble, right? What will lead to excessive production, those red cells, even though they are a lot, they are immature. That's the problem. So the individual will be anemic because the red cells doesn't work. There will be thrombocytopenia because the platelet is being destroyed. There will be neutropenic because your white count doesn't work. You develop what? Pancytopenia. What do? You monitor all those factors. Red blood cell, they may need hypotension alpha. Platelet, they may need the upravecrine, and then the VBC, they may need the grastin, I call grastin. So those are all, they may need some platelet transfusion for the platelet, but upravecrine is the first medication you can use for that. Myelodysplastic syndrome is a progression, right? So this is the overview of all the malignancies. This is just giving you that leukemia is also myelodysplastic disease, right? What is the problem? You have acute lymphocytic leukemia. That means most of them are lymphocyte. or acute myeloid leukemia. They are all the same. You don't have to memorize them. When they give you AML or ALL, a lot of people have get case study, think the same way, right? The symptoms, you have one cells that is destroying the red of cells. Even though you have millions of white cells, it does not work. So you still at risk of infection. You have fatigue because of the anemia. You're going to develop and bruising because of your platelet. Your lymph node is going to get swollen. You lose weight, right? So your lab work, all these things, you will show up. Treatment is chemotherapy, and then put them in neutropenic precaution. You know, neutropenic precaution. Hand washing is good. They cannot eat fresh vegetables, right? They have to be alone. They make sure they get vaccination. They have to drink from water bottle if they travel, right? They can't eat from the hot dog stand. All those things you should be, and avoid live vaccine. All these things you should know, right? Polycythemia vera is a good information you should know. It's a case study that they can give you. It's also myelodysplastic. It's a form of cancer, basically, but you have overproduction of red cells. This is the red cells is producing too much. Um, in the process, if your hemoglobin is like 14 and you have too much red cells, it can go to 18. The blood becomes very viscous. It can flow. So if blood slow down, it can flow. It form clot. So what is the problem with polycythemia vera? Symptoms of clot, right? They have headache because blood is not going to your brain. You can have dizziness, blood vision. These are all stroke-like symptoms. You can form DVT, right? You can have due to you can have bleeding because what will happen, your platelets will become immature, they can consume from that, and you have pruritus from excessive bilirubin deposition, right? And your spleen will sequester. You get bigger and bigger and bigger and sequester your platelet also. So they get splenomegaly. So if they give you a question with somebody whose hematocrit is high, it's itchy, it's bleeding, he has headache, you know, it's polycythemia vera. Treatment, vampire them. Go and remove all their blood. So they may go 3 times a week to get their blood drawn, and give them aspirin to prevent clot formation, right? You want to prevent them from forming clot, and the platelet can form clot. So you give them aspirin. Hydroxyurea is a form of chemotherapy. It suppresses the bone marrow production. And then hydration to make the blood less viscous. These 4 things you have to know. It can give you a case. Somebody have had a case study like that before, and it's very straightforward. These are the keys you have to know. Multiple myeloma is a myelodysplastic cells, and it's due to abnormal overproduction of antibodies, right? These people, they can go into the bone, and so therefore your calcium can be elevated. It can affect your kidney function, become anemic because you have overproduction of the bone marrow, and they can have fracture, pathological fractures. The most important thing is to get rid of the calcium. This is what makes them sick. They can go hypercalcemia is not good. So hydration, pain management, and the monitor for signs of infection. All of these malignancy infection is the key. Lymphoma, all you need to know is the 2 types of lymphoma, Hodgkin's and what? Non-Hodgkin's, right? These are also malignancy involving the lymph nodes, right? They will present the case like somebody who have TB. I call them B symptoms. They will come in with the B symptoms. They have pain, they have lymph node that enlarged. They have fatigue, night sweats, weight loss. You think they have TB, but you got to pay attention. They've not traveled anywhere, and you know that this patient has lymphoma. The difference between them, Hodgkin, non-Hodgkin lymphoma is more aggressive and widespread, right? It can involve extranodal disease. That means it can involve your spleen and other organs, right? Hodgkin's is mostly localized to the lymph nodes, but the treatment is the same thing, chemotherapy. So if they give you a question, don't worry. Key fact is the lymphoma with the B symptoms. Treatment is the same. One is extranodal, one can be localized to the nodal system. Now they talk about this neutropenic precaution. Neutrophil is low, less than 1,000, right? You start watching them when it's less than 2,000, but like less than 1,000 is really, really, really bad, right? It's due to chemotherapy or bone marrow suppression. And as usual, fever, always bad. They're going to have sore throat, skin infection. You monitor for signs of infection and you teach them how to prevent infection. Treatment is to increase the VVC, and what we use is filgrastim. This is going to stimulate red blood cell production. I told you about raw food, flowers, hand hygiene, all these things are very, very important. Like I told you, this is our summary that you at least you have an idea what is going on. Tumor lysis syndrome. If you have a cancer, we give you chemotherapy. We're going to break the cells. The cells, there's certain electrolyte in your cells, and there's certain electrolyte outside your cell. So when we give you chemotherapy, there's a rapid breakdown of release of intracellular content, right? You have more potassium inside the cell. You have more phosphorus inside your cell. You have more uric acid inside your cell because of your DNA. When I give you chemotherapy and I destroy your cells, you have release of all these things. You get hyperkalemia, hyperphosphatemia, uric acidemia. When potassium is high, well, arrhythmia. When phosphorus is high, it's going to make your potassium low, your calcium low. You go into seizures like tetany, right? Uric acid can damage your kidney. So these are the three electrolytes you pay attention to. Your management is based on that. And their symptoms is based on that too. So they have nausea, vomiting, seizures, arrhythmia is all it all makes sense. Nausea, vomiting, and seizures related to hypocalcemia. I Arrhythmia is related to hyperkalemia, right? Flank pain is all related, and oliguria is due to kidney failure. Therefore, monitor all these electrolytes, calcium, potassium, uric acid, and cat. The most important thing you should do, hydration, 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 then give them furosemide to wash things out, right? You put them on the EKG, protect their heart, right? And then destroy or give them phosphate binding chemicals to lower their phosphate so that you can increase your calcium, right? The uric acid, you know about allopurinol. This is what we can use, or raspberry case. This is another medication that you can use, right? Calcium gluconate is for the hypocalcemia, and then you manage their hyperkalemia. This topic is very detailed. It shows when you get hold of this topic, it tells me that you know your content, tumor lysis syndrome, because there's so many things happening and you have to manage everything when you need to do. There's some emergencies that you're supposed to know. Acute chest syndrome, we talk about it. Sickle cell, hydration, pain management, and fluid. How would they present? Well, they're going to have chest pain, fever, hypoxia. They are really bad. Usually, most patients with sickle cell does not have chest pain, but if they start having chest pain, that is your key. Chest pain, fever, hypoxia is acute coronary syndrome. It's not crisis, it's worse than that. And this one, if you don't do anything, they're going to get into trouble. I talk about hyperviscosity syndrome. That is polycythemia vera, too thick, blood, viscous, causing blockage. They having stroke. And we talk about massive hemorrhage from the DIC. You see, this is the same thing. It's a content all connected, where they're going to bleed and bleed and bleed. Prioritization 101 is ABC. Replace the consumption of the blood products, so RBC, platelet, and FFP, and treat the underlying problem, which is DIC. Hypercalcemia is very common in cancer patients, especially multiple myeloma, and you have to know how to manage it. What is your treatment for hypercalcemia? How would they present? They're going to be weak. They're going to be confused. They're going to be depressed. These are classic symptoms of hypercalcemia. Like they'll be mourning, they'll be groaning, weakness, confusion, arrhythmia, constipation, kidney stone. These are classic hypercalcemia. What is your number one? Hydration. Wash them out. A lot of fluid, then wash the fluid out with furosemide. So a lot of fluid followed by furosemide and then phospholipid binders to help with that. the bisphosphonate to prevent bone breakdown. This you have to know, splenic sequestration crisis is very, very key. Sickle cell patient, right? Their spleen is supposed to be small. The spleen get infected from black clot, right? So their spleen is small. If the spleen is big, that means the spleen is trapping a lot of blood cells and they get enlarged and they have pain. So any sickle cell patient with the left upper quadrant pain is a priority. It means they're going to go into shock. They will become hypotensive. So the treatment is emergency surgery. Don't forget about it. Spleen, sickle cell patient's spleen should never be painful. If it's painful, it's being sequestrated, and that's a crisis. HEP syndrome, you know about this. OB is related to basically emergencies, hematological problem. We have hemolysis, elevated liver enzyme, and low platelet. This is pre-eclampsia spectrum, right? Right upper quadrant pain, they have hypertension after 20 weeks, right? And hypotonuria. The baby need to be delivered as soon as possible. This HEP syndrome is more dangerous than pre-eclampsia. You can also develop DIC in pregnancy, especially placenta abruption with the placenta embolized, and then you have consumption of your coagulation factors. You develop DIC, you know how to treat them, replace the clotting practice. Bone marrow transplant is indicated for patients that you have like lymphoma, leukemia, plastic anemia, anything that has destroyed the bone marrow, right? It can be from yourself or from another person, right? Number one, your board will ask you graft versus host. That means I give you something and we fighting. So you receive a bone marrow transplant and your body is fighting against it. So graft versus host disease is an immune attack by the donor cells on the host. So they're going to have rash, liver failure, and GI symptoms. That is bad. It's a sign of rejection. Field pharmacology. We already talk about it. Iron supplement. If you have iron deficiency anemia, you take it with vitamin C, right? You avoid calcium, no milk, right? You're going to have constipation, and then you have to know how to manage it. This little farm is a comprehensive farm that you need to know every little thing, small things about them. That's what your board is going to ask you. Vitamin B12 is usually pernicious anemia. Usually it's going to be injected the rest of your life. Folic acid, you develop megaloblastic anemia. Usually pregnant ladies, you want them to get 400 to 800 milligram. Teach them about things that have folate, like fresh leafy vegetables, cereal, fortified, even peanut butter. I talk about erythropoietin, right? Erythropoietin is used to increase your blood cells, especially people with kidney disease, and they need to improve their white and red blood cells. Or you're on chemotherapy, your red cells is down. We give it to you, but we cannot give it to you forever. We just need to increase your hemoglobin by 1 gram. So if you reach to 12 gram per deciliter, we need to stop it. So the idea is 1 gram. Otherwise, if we do that, you're going to you develop stroke. So even 1 gram increase, we need to stop it. And the priority intervention for hypotension is hypertension. Heparin, anticoagulation. You say heparin, you monitor PTT. I told you the normal range, you just multiply by 1.5 to 2.5. There's a risk of heparin-induced thrombocytopenia. You only monitor this when you're getting IV heparin, not sub-Q heparin, which is enoxaparin. You don't need to do anything. You don't check APTT regularly, right? So that is the key. You don't need to modify your diet. You don't need to decrease your vitamin K, no diet modification. If you're on warfarin, we need to check your INR and PT, right? You don't need to modify your diet. That's another key. Your board would deceive you with these medications. No need to change your diet. If you eat vitamin K dependent factors or you eat a lot of fresh vegetables, I want you to stay. The word is consistent amount. If you change it, it's wrong answer. So consistent amount of vitamin K rich food for warfarin is good answer. Hydroxyurea, you saw it, we use it in, um, we can use it in Polycythemia vera, and also we can use it in sickle cell patients. So they're very, very good, right? In sickle cell, it decreases sickling and reduction of your red cell in a Polycythemia vera. It can suppress your bone marrow. Desmopressin is used in hemophilia, and he increases your factor 8 level and vulnerable factors. So these, when you see a question about a patient with von Willebrand disease or hemophilia A, you can give them desmopressin, DDAVP, right? Desmopressin, and that will increase your factor 8 level, right? It can act like a ADH, but in this situation, we're talking about increasing your factor 8 and von Willebrand. You know allopurinol, right? This is for patient who has gout, who want to prevent excessive uric acid production. You can also use it in tumor lysis syndrome. It's a sulfur drug, so you got to monitor for what? Stevie Johnson syndrome. Once again, straightforward information. Raspberry case is also used to decrease your uric acid level in tumor lysis syndrome. Fibrinolytic is basically we're breaking down clot, we're just destroying them. Plus, you have to know implication, complication, indication, because it causes bleeding, right? And your board wants you to know that. What are the indication, right? You should not have any surgery. For a couple of, at least 14 days, and stroke, head injury for 30 days, right? You should not have hypertension, uncontrolled. There is complication. If you have stroke, you should be within 4.5 hours, right? If you have heart attack, it should be 12 hours. Otherwise, we're not going to give it to you. So go look for these medication, specific indication. There's a lot of videos I have on it. Indication for Anaphylaxis, your board will like it when to give it. When it comes to blood transfusion, straightforward, right? Blood product, there's your red cells. It's for anemia, platelets. It's for thrombocytopenia, frozen plasma. It contains clotting factors. Therefore, this is what we use in DIC. We need to give you clotting factors. Cryoprecipitate contain fibrinogen, which also help with bleeding. How do you give blood, right? First, you got to verify ID, the blood type, cross match with another nurse. That means you got to verify with another nurse, not the UAP, right? Make sure they have a bigger IV, 18 gauge or 20 gauge is okay, right? And it has to be infused within 4 hours, right? Anything after 4 hours is not efficient, right? First 15 minutes, you are responsible for checking the vitals because that's where reaction will occur. After that, you can delegate to the UAP. You monitor for reaction. If the reaction occurs, stop the poison. Number one, the first sign, stop it. Keep the IV open. Don't take them out because we got to give them fluid. It's very, very important. Keep the IV line open with the normal saline running through that. Notify the air care provider and the blood bank. Collect all this specimen that you need. Monitor your patient vital and send them back. These are the steps. If they ask you, what are the steps? Some patient is receiving some blood and is having reaction. These are the things you do. You stop it, first sign, keep the line open, notify the air care provider and blood bank, check the patient vitals closely and send the tubing. Don't destroy them. There's a principle in blood transfusion. Universal donor is what? O negative. They can be transfused to any blood type if they lack what? A, B, and RH antigen. What does that mean? If I'm transfusing blood to you, okay, I should not have what? What is the key? You have to understand if I'm giving you blood and you're going to receive it, then my antibody should not be reacting with your antigen. My antibody, okay, should not react with the antigen. So if you send me in blood, you should make sure you don't have any antigen on you that my antibody can react with that. AB blood group O has no antigen, so nobody can react with it, so they can give it to everybody. universal recipient, it has no antibody to react with somebody antigen. That's why AB is a recipient. He received blood from it. So this is the concept. The antibody of the recipient react with the antigen of the donor. The Rh factors you have to know, you can memorize it. So Rh positive can receive blood from both negative and then Rh positive blood. But Rh negative can only receive blood from Rh negative. So if you are positive, you can receive blood from a positive and a negative Rh. But if you are negative, you can only receive blood from only negative. And this is a simple table for you to think about it. So this is Rh. Blood group O can give blood to blood group O person, and the negative, because if it's negative, it can only give it to negative. But positive, blood group O positive can give to both O negative and O plus, right? These you have to, you don't have to memorize this table. If you memorize it, then you're wasting your time. I said concept. What is the concept? Blood transfusion. The recipient, okay, should not have antibodies to react with the antigens on the what? The donor. What is blood group A? Blood group A has what? Antibody B. Therefore, if somebody with blood group B, send them to blood group A, blood group B as blood group A as antibody B, that will react with the antigen of antigen B, and therefore that's why they can do that. And that's all. And if you're negative, you can only give it to negative. If you're positive, you can give it positive and negative. That's all. That's why blood group A positive can give it to all positive and negative. And who can they give it to? You can give it to A because A does not have antibody A to react with them. And um, the recipient here is not going to have an antigen for this antibody B to react with that. So this is like compatible. You can do any combination you want, just the concept. Okay. There's some few hematological topics you got to know, and I want to make it easy so that if they give you a table, it's straightforward. When we get reaction from blood, the first thing we can have is febrile non-hemolytic. That means you just have fever. It's not hemolytic. That means nothing is breaking. You're not going to get sick from it. You're just having fever from the blood transfusion. And what happened is the recipient antibodies react to the donor white cells. When I arrive with the white cells, my white count goes up. So they're going to have signs of white cells, right? Fever, chills, headache, flushing, and muscle pain. But there's no hypotension, there's no respiratory problem. What you need to do is stop it temporarily and give them some antipyretic, like acetaminophen will take care of it. Hemolytic means your blood is reacting with my blood, like there's non-compatible. So it's incompatibility. Keyword is flank pain and change in your urine color. You see the difference between febrile and non-hemolytic and hemolytic. There's flank pain, hematuria. That means if you see those things, that means blood and blood are reacting, incompatibility. And therefore, you're going to be bleeding, hypotension. You're going to have tachycardia. You can have DNC. Your urine would look dark. You're going to renal failure. You get shock. What do you need to do? Stop the blood immediately, like we talk about, maintain the IV fluid going, notify the healthcare provider, send the blood bank, and monitor the patient. There can be allergic reaction. There's malform. It's different from anaphylactic. A reaction to plasma in the blood. You can have allergy, and usually they will show some flushing, urticaria. This is stop them temporarily, give the antihistamine. It's different from anaphylactic. There's shock, right? Allergic reaction to donor plasma, and you're going to have what? Wheezing, hypotension, cyanosis, and shock. That is different from mild allergy. So anaphylactic shock from it, yeah, you stop it, you control sepsis, epinephrine, oxygen, and steroid. Circulatory overload. That means I give you too much blood quickly. And when they give you a case form, you see patient will be in heart failure, right? They're going to have signs and symptoms of heart failure, dyspnea, cracking, hypertension, JVD, and headache. Those are signs of circulatory overload. What do you mean? Slow down the transfusion. Stop it for a few hours and then slow down a few minutes and then elevate the patient head, give them diuretic, and then you can resume it. But it's very, very important. They are fluid overloaded. So control the fluid overloaded situation, then you can resume the blood transfusion. It's different from transfusion-related acute lung injury. That means the lung is being attacked by the blood product. There will be sudden dyspnea, fever, hypotension. You see, there's no signs of what? Lung overload, fluid overloaded. That's the difference between trailer and circulatory overload. You stop the transfusion, provide oxygen, and notify the blood bank. It's because the blood product is destroying the lung tissue. This is the end of it. I hope you gained something. Hematology for business and student, concept review. Happy New Year and take care of yourself. If this video was helpful for you, join our doctor class. You can subscribe down and share the video with your friends, or you can join our membership, or you can check our crash course website or our on demand. Take care and Happy New Year again.